talk about providers, there's a lot of different definitions out there. If you are talking to a commercial payer and you say provider, they might be talking about health system or like a facility. That's not what we're talking about. We're talking about an individual who is appropriately licensed and credentialed that provides direct patient care, that can bill and collect for those services. Terminology is pretty important. There's some words I wouldn't use. I don't know if anyone's gone through this, but I would not use the word mid-level or extender. Those are words you will see in regulations and Medicare manuals. If you go to a room full of APPs and physician assistants and you say these words, you will probably just be shot right on the spot. You better be prepared. You got your tennis shoes on and get the heck out of Dodge.
Language evolves over time. So, like when I was first learning health administration, they were called physician extenders. And then, there was sort of the backlash that was seen as derogatory. So then they became mid-level providers. And then now that's no longer acceptable and it's advanced practice provider. So it's just sort of interesting the way those types of things evolve over time.
It is. I find a lot of physicians now find that take issue with this too. They're saying like we're physicians and we're differently qualified and we want to be defined a little bit different. So I've been hearing the term physicians and clinicians as another area that I kind of see in some areas. I just kind of go with the flow, whatever I'm told to say. I don't know if that's appropriate, but I've learned the hard way a couple of times on mid-level. That was a tough conversation. I went into a room and I accidentally used the word mid-level and I got a severe beating. The one area that's unique to is like the hierarchy. So if you're talking to a physician comp professional or fair market value and they use the word physician, they're really talking about MDs and DOs. And then they'll use other doctors. It's not a knock against those other areas, but this is just the area that they were really honed in on is MDs and DOs. And then we kind of group all advanced practice providers together. So nurse practitioners, PAs, CRNAs, nurse midwives, they're all typically grouped together. And then non-physician providers. So this is just really any other types of folks that you can bill and collect on the physician fee schedule for. Most organizations, you're probably not going to be responsible for this, but it's a growing trend. And I think this is really twofold. One is team-based care is becoming more a strategy for most organizations. And so in order to do that and facilitate care coordination and management, you need to have all your providers aligned and compensation alignment for that. So I would say this is an area that most organizations are transitioning these folks underneath the provider comp purview. And then, we're just real quick, we're talking about some of the services. Most of the time we're talking about patient care, evaluation, surgical items, the ancillary services as well. This just becomes very important when you're looking at fair market value. What was done in the office, what was personally done by the provider. And another area that's getting a lot of attention is supervision. So you have supervision of APPs when a physician supervising a nurse practitioner. This is, I would say, a controversial area because how many folks get paid directly for the work that you supervise for somebody else? It's a leadership position. You have to think about the economics of this situation as well. How much are you paying the APP? What is the revenue that's coming in? And so a lot of physicians will get like an APP stipend, or maybe you group the production together. It also depends on the state laws. What state do you operate in, and how does the APP operate? Most of the time, If it's like an urgent care, the APP is going to be fully independent, not a lot of supervision. Maybe they're just doing pre and post-op work, or maybe they're just at the hip of the provider. They're kind of misusing them as scribes, which is not very good use. It's a very expensive scribe. Telemedicine is kind of being supervised to deliver telemedicine. And then academics, they have 3 definitions there: direct, indirect, and oversight. That's very similar to the Medicare definitions for diagnostic and therapeutic services. So this is kind of just important to understand: where was the physician, where was the provider or the APP, and then who did the billing for the services, and then who rendered the services there. And that brings up Incident 2 services as well. This is really where an area you think about Incident 2, but you bill underneath a physician's NPI. Maybe the APP did a little bit of the work or a substantial piece of the work, but you still bill it underneath the physician. You get 15% more money. So an APP typically through Medicare gets 85% of what a physician would get. So this is a financial strategy in certain situations where you can have an APP that's making $130,000, $150,000 do the services, and you have a physician that does the billing. You get 100% of it, but you're paying the APP $150,000. You're paying the physician $350,000, $400,000. They can go out and do other types of services, more lucrative services.
So going back to residents.
Yeah.
Do you have different provider compensation models for residents compared to attending?
Yes.
Physicians?
Yeah. Well, so a resident doesn't get paid much. Like what, 80,000, 70,000 probably.
Yeah.
Most of the time they just get paid a flat salary from the AMC.
Monitoring their work RVUs or anything like that?
Their work RVUs are probably going to be billed underneath the physician,
Okay.
the attending physician if they're doing clinical work. Now, some residents, if you're doing like specialty work, say if you're like a cardiologist and you're going through that program, you can moonlight at a competing hospital across the street. So you can't, it depends if you're accredited or not accredited program. And there's restrictions on the hours for the AMC that you work for, so for the GMC piece. But you can get around it by going to the other system. So like a lot of times when I was, say, at Banner, Creighton was across the street from us. We would do some agreements with those folks that were going through the residency program. And then Dignity, which was attached with Creighton, would do that with ours. So very small stuff would be like, hey, we just need a physician on site at a cardiology lab. If anything goes wrong, they absolutely do nothing except for like probably sleep or watching the news or catching up on stuff. They just physically have to be there. And we would pay them $150 an hour. And it's because we can't operate the lab without a physician. And not a lot of people are going to accept $100 to $150 an hour. I mean, I would, but in the physician world, they wouldn't. So best way, you can staff that with some residents and fellows. So that's interesting. Yeah, that's a good comp. That's, and then that's also an area too, where you get, I would say recruitment incentives for, future employment, which is a very hot topic area right now. Call coverage. This is a pay practice that has changed over time. There's really kind of 2 types of call. There's practice call. So if you're a family medicine physician and a patient calls you, you're responsible for that patient, right? You have an obligation. That patient is assigned to you. You think about facility, this is like the hospital. So this includes unassigned patients who does not have a relationship with that physician, but presents to the hospital or is in the inpatient area that has an emergent situation. That's a situation where now a lot of organizations are compensating for that pay. A couple of things about that. One is they couldn't attract enough physicians to do this. This is really a service that's an obligation from the hospital, depending on what your level of trauma is. But the hospital is required to make sure that those services are accessed. So physicians have no obligation to provide services there. They also typically, when you go to a hospital in the ED department in particular, most of the time that's underinsured or uninsured patients. So you're typically not going to get paid for those services. So the physicians will say, hey, I want a little extra compensation, not just for the time burden that I have to be available. I have to be sober. I might have to leave my house and present, but I'm not going to get paid. I'm going to come in and do an operation. I'm going to be here for 3 hours. I'm not going to get paid for the services. Help me out. So typically for emergency call, you see a lot of organizations outsourcing this, but there's been a lot of turbulence in this area. So you think of, how many people know KKR? Private equity firm. They owned Envision. Anybody know Envision? So they are one of the largest operators of emergency medicine, or they were. And most health systems contracted with them to have all their EDs staffed with these providers. KKR was a private equity firm, and they basically went bankrupt, and it's been disruptive in the marketplace. But the goal is to basically have exclusive arrangements with large systems. So you, as a health system, hey, I don't have to contract and worry about the services. Maybe I'll lose a little bit of money on the services, but I don't have to worry about it. I don't have to have the headache of managing it. I guess the last comment I would make about call is that there's two types with hospital call. There's restricted and unrestricted. Unrestricted means that you don't have to be on the facility, but you typically have to respond by phone within a certain amount of time, and then be able to physically present at the hospital too if needed. So you might hear respond within 5 minutes, present within 20 minutes or 30 minutes. And that really depends if you're like a level 1 trauma center or just a hospital that's kind of in a rural community. It might be a little bit different. Restricted, that means you have to be on site 100% of the time. Doesn't mean that you're seeing patients all the time. This means you're physically there. Most of the time it's for like trauma. It's probably the area that you see that the most in. And then physicians can do some administrative services. It's usually clinically related or non-clinical related. Apologize, I'm an accountant. That's how we think. I think the comment I would say, if it's clinically related, sometimes this is an obligation to be accredited. So if you are a dialysis center and you have a freestanding dialysis center, you have to have a medical director. So they usually typically have to work 20 hours a month. So that's mandated. A lot of them are not. The other important thing to think about is, do you need a physician doing these services? And this is where regulations really caught up to some folks. So do I need to have a neurosurgeon to do ACO, family care planning? Probably not. It's not required that you have specialty care in neurosurgery. So you don't need to pay a neurosurgeon $650 an hour to sit on this committee when you can pay a family medicine practice. Is probably a little bit better suited. The last services too is academics and life sciences. So most physicians, even if you're employed, say at VCU Health, you're probably going to do some outside work. You're going to do some consulting for a life sciences company. You could do a PI or sub-I work arrangement. Maybe do some medical direction work with them as well, some thought leadership. This is an area I would say if you're managing it, there's some risk in it. You want to make sure you're not misappropriating resources. So are they doing clinical research on patients for your system? Has that been approved by the organization? Are they using your computers, your data, your information? So this is an area I think it's not a lot of money, but it's typically an area that's misappropriative of other resources.